Good afternoon, everyone. Thank you for the opportunity to be here today and present. My name is Anand, and I'm presenting our work today on radiofrequency guidewire-assisted central venous occlusion recanalization for symptomatic superior vena cava syndrome in 2 dialysis access patients. I have nothing to disclose. The first patient is a 57-year-old female with end-stage renal disease from IgA nephropathy who is on dialysis via right brachiocephalic AV fistula. She presented with right arm and facial swelling that developed 13 months after her AV fistula creation. Of note, this patient has a pretty complicated medical history. She initially had a tunnel dialysis catheter infection that resulted in mitral valve endocarditis, for which she required urgent mitral valve replacement. Her case was unfortunately, post-operative course was unfortunately complicated by a vasopressor-induced ischemia resulting in gangrene of her peripheral extremities, and she unfortunately had to have partial amputations of 3 of her 4 extremities. So not the ideal surgical candidate. So when she presented, we took her to the angio suite, and we saw this on our angiogram. We got access via the right cephalic vein as well as the femoral vein. Of note, she had seen 2 other providers who had tried endovascular techniques via conventional approach, but failed. And so when we took her back, we again tried using conventional techniques to cross this occlusion, but failed as well. And so from the femoral wire access site, we introduced a radiofrequency wire. And using this wire, we were able to slowly cross the lesion and get through and through. Once we were able to cross this occlusion, we then used a snare to grab the wire as well, and we threaded a catheter from the femoral vein. So we used the snare to grab the wire as well as the catheter, exteriorize it, and then removed the wire, and then placed a longer through wire. And over this wire, we put a balloon. And then using the balloon, we were able to plasty the vessel open. And then after we plastied the vessel, there was still some residual stenosis, and so we put a bare metal stent in. And the completion angiogram shown in the final image shows the return of patency of this vessel. The patient tolerated the procedure quite well. She was discharged home from PACU. On return to follow-up, she had marked improvement in her symptoms with decrease in the swelling as well as the prominence of her venous collaterals. And since then, she hasn't had any problems and hasn't had to come back to see us. The second patient is a 31-year-old female with end-stage renal disease from systemic lupus who is on dialysis via left brachiobasilic AV fistula. She presented with left face, neck, and arm swelling 4 months after her second-stage procedure. Of note, this patient is actually a transplant candidate, and the transplant surgery team, after hearing about her problem, had asked us to try every means we could to stay endovascular and not use an open approach. And she had seen an outside physician, and they had tried endovascular techniques and had failed too. And so when we took her to the angio lab, we got access via the left basilic vein as well as the femoral vein, and then we saw this. Significant occlusion, which we again tried to cross using conventional techniques, but were unable to do so. And so we used the radiofrequency wire from our femoral venous access site and slowly made our way to cross this lesion. Of note, the difference between this case and the prior case is that we used a catheter as a guide from the right cephalic access in the previous case. In this case, we used a snare. And given the trajectory of the left innominate vein, we were very careful and took longer time in this approach. But we were able to, again, cross the lesion. We placed a catheter from the femoral site and snared both. Then we exteriorized the catheter and then put a longer through wire in, and over which we performed plasty. And then in the third image, there was some residual stenosis, so we put a bare metal stent over this. And in the completion angiogram, we were able to show patency of the vessel. This patient, again, tolerated the procedure quite well, was discharged home from PACU. She had a significant improvement in her symptoms upon follow-up. And even better news, she underwent a living donor kidney transplantation 1 year later, and then was able to get her fistula ligated 2 years after that. So from this case, dialysis catheters are the most common cause of benign central venous stenosis, and SVC syndrome can occur with an incidence of up to 40%. And SVC syndrome can cause catheter malfunction, can reduce fistula patency, and can lead to significant patient discomfort, as in these 2 patients. Although of note, 50% of these stenosis or occlusions can be asymptomatic if significant collaterals are able to develop. over a chronic period of time. And the indications for intervention include significant symptoms, impending catheter fistula failure, as well as catheter fistulas that have failed. And the options are endovascular treatments to recanalize the vessel or open bypass, although open bypass can be quite morbid. The radiofrequency wire, for those who are not familiar, can be used to burn a channel through an occlusive lesion. And once the lesions cross, allow standard deployment of a balloon to place the lesion open, and when needed, placement of a stent. And it's indicated for use in occluded peripheral vessels greater than 3 millimeters. The wire itself is an 035 wire, that comes in straight and angled configurations. It can be placed within a 4 French sheath and is connected to an external radiofrequency generator. 24% of central venous occlusions are unable to be crossed with conventional endovascular techniques. And so the radiofrequency wire has been shown in studies to be effective. Now, in one single institutional data, they studied 43 patients who were treated with this radiofrequency wire. All of them had previously failed standard techniques. And they reported 100% intraoperative technical success, and at 9 months follow-up had primary patency rates of 95%. So in conclusion, endovascular recanalization is a preferred treatment for central venous stenosis occlusion, particularly in symptomatic patients. However, you should consider the radiofrequency wire when prior endovascular recanalization attempts have failed, particularly in patients who are not good surgical candidates. Our work has shown the feasibility of using this to recanalize the vessel, as well as plasty and stent it in patients who have AV fistulas. Thank you for your time.